pain, that medically elusive evil? What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, number 25. Welcome to the Pain is Not the Only Problem podcast. Article 25, Pain is Not the Only Problem, Advanced Imaging, Part 2. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction, and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Diagnostic competence is the physician's diligence to the highest standard of professionalism, a duty to completeness and excellence in medicine with cross-culture respect. Waite et al. 2016 recommends 4 non-technological solutions to reduce interpreter error. 1. Optimize their experience by offering ergonomic features, by offering enhanced lighting, offering breaks and naps, and social interaction. Also, by reducing uninformative interruptions that occur during error-prone scenarios. 3. Double reading benefits to accuracy and completeness and methods to reconcile discrepancy between readers. And 4. Non-punitive approaches to performance improvement, self-disclosure of mistakes. There are many important organic low back pain findings that can be seen on advanced imaging. These findings may seem novel, however, I would argue strongly for their interpretation and representation in a low back pain report. Number 1, fatty replacement represents an infiltration of fat marbling within the muscle belly. Fatty replacement is an excellent indicator of a muscle use change from stronger to weaker. For example, in the lumbar spine erectors, and I've also seen this in the psoas. 2. Thickening of non-contractile tissues indicates an increased reliance on hard tissues, such as tendon and ligament, to provide structural tension and trussing in the absence of spinal stability or muscle belly diameter. 3. Flattening of muscles related to density indicate muscle bellies in high tension, not to be confused with 4. Diametric reduction of muscles indicating weakness. A flat muscle indicates high tension. A reduced diameter muscle indicates weakness. Underdeveloped muscle bellies, even in adult patients or athletes, notably at the psoas and abdominal walls. Low back pain studies should include the surrounding core musculature, to include the transversus, the respiratory diaphragm, and of course the pelvic floor. Classical advanced imaging interpretation includes the usual organic low back pain suspects. However, in this list, I have omitted disc herniation classification and spinal cord impingement due to lack of evidence. Instead, the list includes primarily contributors to root imbrication, instability, alignment, and inflammation. This list includes, number 1, thickening of the corpora transverse ligament, possibly contributing to nerve root imbrication. 2. Densification of the spinal and lumbosacral ligaments. Number 3. Measurements of the spinal curvatures and vertebral alignment that are a result of and contribute to spinal instability. 4. High signal or sale signs, etc., indicating inflammation and swelling. Number 5. IVF encroachment factors such as fat, bone, nerve inflammation, or tumor. And 6. Cord pathology, including tethered cord, Chiari malformation, and cauda-equina syndrome. Anderson 2008 tells us this: help patients understand the current evidence about the limited value of immediate imaging in cases involving nonspecific low back pain. Case study: a 22-year-old right-handed female collegiate soccer player, a wingback defender, is complaining of nonspecific low back pain when she traps the ball with her left foot, and right shin pain related to a traumatic injury since a game 3 days ago. What questions would you ask of her? What do you know about the demands of her position as a defender and how it might contribute to the diagnosis? According to Wikipedia, specifically wingback defender with 60 citations, cited April 30th, 2019. A wingback defender is one of the most physically demanding, more often adventurous, and expected to provide width and need to be of exceptional stamina to be able to defend against opponents' attacks down the flanks. Consider the demand of aggressive lateral leg work and likelihood of blunt force contact, the sudden decision-making, and automatics required to steer her body athletically through the game, beginning to end. Playtime goes until a foul is called or a goal is made. She is an inspired young athlete, willing to deal with the demands of the sport. She didn't choose archery. Is she pushing through pain? Does her coach allow her to push through pain? What kind of in-house therapies does she get? Are they working? What is her training and recovery experience? What is her nutrition like? Is she injured often? Is it the same injury? Is she left or right-footed? Did you even ask? Is she watching videos of her practice and her game time? None of the aforementioned points can be seen or answered using advanced imaging. It is gross negligence and unprofessional medicine to simply aim the patient toward imaging without genuinely learning about the patient and their values and learning about the specific impeded sport or skill. What is your diagnosis? The purpose of this imaginary case study is to exemplify the prevailing low back pain patient in the clinical setting. Nonspecific low back pain with other presenting symptoms, whether related or not, and an inability to perform certain skills or duties with or without pain, and with other pain-free performance limitations where there is no complaint. Therefore, a robust conversation with the patient or athlete is in order. In my office, we use soccer balls, volleyballs, tennis rackets, golf clubs, baseballs, and softballs to get a better sense of the patient's functional and symptomatic mechanics. We review videos together of their performance, screen shared on a 75-inch television, or YouTube videos that I've made, or I meet with them at the tennis court, at the track, or on a field. Detailed attention to patient specificity has been lost in the field of medicine. It has been diluted down to the sweep of a pen or an imaging order. Old habits are just that, old and habits. Maybe we need to take another look at the science and ourselves. Isn't it easy to agree that pain is not the only problem? Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.